Why do health reform if the economy is in such bad shape? Why don't you pick on something easier? Why take that on? That's the biggest single misread of health reform in the U.S. today. Health reform is not an end in itself. It's a means to an end. And the employers in this room can probably appreciate it, though, with all due respect, all of us are complicit in getting us to the problem that we have in healthcare. In the spring of 2009, I get a call from some folks in the White House. I'm fiercely independent. I am a data guy. And they say, what we really need is to figure out a way to reduce by $2 trillion over a decade what we spend in healthcare, while not compromising safety and quality. We just had a photo op on Monday with the heads of the Health Plan Association, AMA, AHA, AdvaMed, Bio, and Pharma, the 6 big trade groups. Noticeably absent, U.S. Chamber of Commerce or Business Roundtable or Conference Board representing business. And the President now is going to take a trip to the Middle East, his first as President, and that's in 5 weeks. We'd like to have an answer from this group about where we can reduce the cost of health care while not compromising safety and quality. Now, I'll tell you where we are. In May of 2009 and January of 2014, we still have the same relative positioning of each of those groups relative to the other. Healthcare is a kind of interesting industry. All of you know this. It's 17% of the GDP. It's 21% of the federal budget. Averages 20 to 4% of a state's budget. 17% of discretionary spending of the average household, second only to housing. Let that sink in. What people miss is insurance premiums and out-of-pocket costs for health care have exceeded wage growth by a factor of 4 to 1 over the past 5 years. 4 to 1. Insurance premium increases through employers or directly pass through to the individual. So we're an odd industry in that when the economy is doing badly, healthcare does well. Go figure. Mike, you understand that? And when the economy is roaring, healthcare does better. I do this weekly report. I was studying the year-end financial results for the industry. Business folks, you'll appreciate this. The S&P's up 29.2% last year. If you take all the sectors of healthcare and blend them into an index, it's up 43%. Biopharma up 57%. The 6 investor-owned health insurance plans up 47%. We're an industry that can figure out a way to make the market work for us. And what I saw at the table in May of 2009, what still happens, is that every sector of the system figures out a way to protect its interest and point at every other sector of the industry and say, you're the problem. I'm okay. You're not okay. And so what we've gotten is to a point where each sector is fiercely defensive of its own and fiercely antagonistic toward the other. And I bet we've got a few physicians in here. There are 110 different disciplines of medicine that are lobbying their piece of health reform. There's no such thing as, quote, the voice of medicine. Every body part has its own voice in this discussion of how healthcare should be managed. But to begin this reform journey, we've got to be fairly honest about it. What we have in the U.S. system is not sustainable, period. Unless, and some would think this a good outcome, unless we think we should continue on its current trajectory where in 2025, 70% of the population will be insured by a government plan. Today, that's 31%. Medicare, Medicaid, military health. 31%. 70% by 2025. And the 30% that are not covered through the government either have no coverage or they're buying in a private concierge market. That's where we're going. That's the current longitudinal trend line. Now, this law is very, very flawed. You'll remember that it was created primarily in the Senate Finance Committee, Max Baucus, you'll recall. And as it was crafted, it was kind of pulling from a lot of stuff that had been done before. And it's got two big parts. Part A is we've got to fix the insurance system so we can cover everyone. On 28 occasions in 2009, President Obama used the following phrase: we have to keep the insurance industry honest. In the State of the Union Tuesday night, I don't know if you heard this slip, but he made this statement. He said, "This is what health insurance reform is about." Because the attention right now seems to be on that part of the law that fundamentally says we're going to change the business model of the insurance industry. We're going to disallow eliminating folks for pre-existing condition. We're going to shrink the risk band so the cheapest products and the most expensive, regardless of your health status, are no more than 300% apart. And if that's not good enough, in every state, we're going to create these marketplaces where you can buy subsidized coverage. And if a governor doesn't think that in Tallahassee or Orlando or Miami-Dade the market's not competitive, we'll allow that governor to create a not-for-profit co-op insurance plan to compete. So the law has essentially thrown to the insurance industry, the 397 operators in this country, the following premise: your business model has to fundamentally change. We're going to use regulatory levers to make sure you don't charge too much. You standardize the products so that they can be compared, so they're understandable to Joe Sixpack at a third grade level of comprehension. And just to keep you honest, we're going to make sure that these exchanges allow for competition. Now, obviously that hasn't gone too well. But you need to kind of understand where that started. It started with two basic facts. One, the public does not trust insurance companies. Now, before others get offended by that, most people don't trust the healthcare system. Doesn't mean they don't like a doctor they see or a hospital in the community. All the polls say the younger you are, especially millennials, people under 45, 2 out of 3 today would chuck the whole thing in favor of a single-payer system. Doesn't mean they understand that. They just don't like it. In fact, Medicare enrollees, obviously here prevalent, are the most satisfied with the U.S. system. The second thing that the front end of the law dealing with insurance sought to do was to find a way to get all these young, healthy people to buy insurance. The young invincibles were to be 40% of this expanded coverage. As of December 28th, 24% of these 2.2 million are under 35. And as it turns out, they're not coming in the door young and healthy. These are the folks that need a meniscus tear repaired and think subsidized insurance will get them some coverage quickly. So the unintended consequence on the insurance side of the law is we're not getting the right group of people to sign up, and we're not getting enough of them to sign up. And at the end of 3 years, 2016, instead of 24 million people buying insurance through the exchanges, it's likely to be far fewer. Just a fact. But the intent was to increase access and to change the business model of the insurance industry so that it's moral, so it's fair. And all the polling says that Joe Sixpack thinks that we as an industry have profited at their expense. The second part of the law says you doctors and hospitals and long-term care providers and ancillary providers, you're part of the problem too. The way we've always done that is policymakers have just changed how much we pay for the widget, for the piece. Business folks in here know that cost is volume times price. What happens in healthcare is you tweak us on price, we just do more. We've done it for years. I was fascinated to look at the incidence of hip replacement and home care visits and open heart procedures comparing the Panhandle to Lee County. Why are so many more people having hips done in the Panhandle than in Lee County? Not just sheer number, I'm talking incident rates. Is it just steeper to walk in the Panhandle and your joint deteriorates in the Panhandle? Why, as it turns out, is the cheapest care often associated with the best outcome, and doing less result in better outcome than doing more? Why doesn't the system know that when a senior takes the 4th and the 5th medication, you're increasing by 20% the likelihood of a drug-drug interaction and an emergency room visit? How did we get to a system where doing more is rewarded? What do you think about that? Interesting data. 27% of what we spend in healthcare is for tests and procedures that are not necessary per the evidence. unnecessary. A doctor that becomes part of a joint venture and owns an imaging facility, within 30 days, doubles the numbers of MRIs done on low back pain. Go figure. Why are only 11% of the folks coming into medical training going to practice primary care? And 89% are going to be in a specialty discipline of some sort. Median income over here, about 180. Median income over here, about 350. And the delta between the two widening. 20% of the doctors directly making more than $500,000 a year. Not taking issue with it, but it's understandable. So we have a system on the delivery system side where every piece makes its own rules, and there's no real incentive to do the right thing the first time. The incentive is to do more stuff as much as you can. And what the law did is it said we've got to end that. It does basically three things on the delivery system side. It says, I'm going to pay for results, not volume. Results, not volume. The biggest bone I'd pick with employers, with all due respect, is you, like most of us, assume that everything that's done needs to be done, and have never challenged the insurance company or the TPA to provide any data to differentiate between necessary and unnecessary care paid for your employees. That ought to be a takeaway from this meeting. That ought to be a discussion you have. The second thing the law does is it said, we're going to do and pay for things for which the evidence says we should do it. There's this huge part of the law that no one pays attention to. It says we're actually going to get all this evidence put together, the Patient-Centered Outcome Research Institute, and we're going to make sure that Joe Sixpack, not just doctors, Joe Sixpack knows that with these signs, symptoms, risk factors, comorbidities, these genotypes, my treatment options are these, and these are the risks associated with those treatment options. Sounds like a pretty good thing. Wildly popular. And the third thing it does on the delivery system side is it said, we're going to force you to defragment yourself. We're going to create Sam's Club versus Walmart competition across regions, not across local communities, across regions, so that long-term care and preventive health and acute care and ambulatory care are all in one entity, and it is paid for results, not volume, and some of what is paid is withheld until you demonstrate outcomes. What do you think about that? Here's an irony, and I was disappointed in the State of the Union that the President doesn't call attention to the parts of the law that deal with the delivery system. It's as if all we're talking about is insurance reform. Does the law reduce cost? We'll see. There's a lot of strong opinion about whether it will or not. Do you think it will reduce cost if we pay for results, not volume, and only pay for things for which there's strong evidence, and force doctors and hospitals and long-term care providers to work together? That conceptually could save money, but no one knows. And it's a big experiment. And a lot of what's in the law is cut and pasted from other things that have been done. And on the front end, the insurance reforms, is this going to result in substantial expansion of access to insurance? Probably not. Is there going to be some incremental increase? Yes. Those people that get that insurance are going to be subsidized, and they're going to be sick. So it sounds like an unintended consequence of front end of the law is that we're going to get a sicker population of insured people. And here's the way that comes down to me and my old job at Vanderbilt. When I had management meetings Mondays, you basically did the math. You knew that people on Medicaid that came to Vanderbilt, you'd collect about 70 cents on the dollar. You knew the people that were on Medicare, you'd collect about 90 cents on the dollar. Now this is a dollar of cost. That's actually what we spent on that widget, not what we charge. Charges are completely irrelevant in our system. Have you noticed that? It's what it cost. For the uninsured, we collected 7 cents. 7 cents. So what we conveniently do, as do the providers in Florida, is mark up what we charged Baptist Sunday School Board, State of Tennessee, Nissan, etc. About 125%. Now, note, it's the same widget. It costs the same, but we just charged and collected at different levels. That's the game that we've played now in this system for 70 years. And it's killing us. It's killing us. Now, where's this going to go? If you've noticed, we're in the midst of campaign 2014. In the off years, last time we went through this, there was a change of 30 seats in the House. I remember doing the Republican and Democratic governors when the numbers shifted from 21 Republican governors to now 30. The dynamic in Washington is going to continue to be in flux. And with all due respect to all those wonderful people up there, we're not going to fix health care in Washington. This thing is going to default to the states. I firmly believe that the story of the next 4 years is going to be how states reform their health care systems. Now, Governor Scott, Senators Rubio and Nelson, you're 27 members of the House. You know, you got an opportunity. Florida's odd. You really are. It's not just newlywed and nearly dead. That only applies to part of the state. It's funny, you're 6.5% of what we spend on health care in the United States. You know that? Tom, 6.5% of the total spend of the $2.8 trillion spend on health care, 6.5% of that spent in Florida. We care about what happens in Florida. Matters. You're an odd state because you have these interesting taxing authorities over some public health systems, and even elected boards in some of your hospitals where people run campaigns to be on boards. You're fascinating because in certain of your markets there is essentially no commercial insurance coverage. Medicare, Medicaid, and the uninsured are the payers. So you're a complex state, and no two states are alike. So I think what you're going to see is the federal government default to some state innovation. It's interesting right now as we're here, the esteem for Congress is at an all-time low. Gallup has been tracking this since the 60s, and the trust in Congress is less than 15%. It was interesting the other night, if some of you saw the network's coverage of the State of the Union, they had President Obama's popularity at 43%. Did you see that data? And I'm sitting there wondering when they're going to show some of the other data. Esteem for Congress is at an all-time low. And what's clear is that Republicans or Democrats don't have a clue about how to fix the healthcare system. And that common sense that seems to be percolating from the business community and percolating from independents seems to be almost by default where we're going. So let me just throw out a few things that might be something we could think about. I think we ought to have a serious discussion about how Medicare enrollees approach their end of life. A fourth of what we spend in the Medicare program, we spend to keep Medicare enrollees alive 40 days. No change of outcome, but it's a fourth. It's a big number. It's an irony that if we address some of that, we could insure all 49 million without insurance and have money left over. That includes the 9.6 million of those who are illegally here. By the way, we're paying for that, aren't we? You're paying for the uninsured. That's the Vanderbilt hidden tax. You're all paying for it. So we're going to have a discussion about this end of life. And it's funny, when you study Medicare enrollees and you study family members, there's strong appeal, strong desire to control those end-of-life options. And almost 90% of these folks would say, if it means that half of my liquid assets go away in that last 6 months, in addition to the government spending that kind of money, let's get reasonable about it. It's interesting. Half of the seniors in that last year facing these extraordinary means of staying alive expend their liquid assets. 58% of those liquid assets. That's college tuition for some grandkids. And we ought to have that discussion. It ought to happen in Florida. By the way, anecdotally, you remember death panels? August of 2009? That was in a House draft of the law the following. We think any senior that wishes to have a conversation with their primary care clinician about their end-of-life care, there should be a code to which that primary care doctor can bill for that 1-hour consult. Mike, that became death panels. It's just not right. Here's another idea. Do you think perhaps the business community in Florida should be the leading state to only pay for things for which the evidence says it's necessary that it be done? Simple idea. You think that's something that we should have on the table in Florida? Now, why do we do a lot of stuff we don't need to do? First thing that comes up is we get sued if we don't. Fair point. Litigation costs 2%. $54 billion a year is what we spend on litigating negligence. 27% is what we spend for unnecessary care. So maybe lawmakers in Florida can get about protecting doctors who follow the evidence from frivolous lawsuits because there's a substantial amount of unnecessary spend that's being done under the guise of I'll get sued if I don't. The data says that's just simply not the case. You make a lot more money if you do more stuff. Period. That's the reason we do it. Here's the third idea. Seems to me the problem of obesity and type 2 diabetes and heart disease and these others. Interesting study out today in the New England Journal of Medicine this morning. Followed these kids from kindergarten through 11 years of age and said, if you're obese, which was the 13% of kindergartners are obese, you're obese in kindergarten and you maintain that to your 11 years of age, you're just going to get worse the rest of your life. It's amazing how much of healthcare begins to tiptoe into education, tiptoe into human services programs, tiptoes into what we do with environments. Maybe Florida could be the first state in the country to capitate and manage children's health through a medical home model. Now, that's not going to bend the cost curve near term, but it will long term. It's not being done anywhere. Closest we have is in Arkansas, where the teachers have to report obesity levels on report cards. Report the BMI on a report card. And here's the last idea. Health reform over the next 3 years is going to be a lot of stories like you've seen for the past 3 years. Depending on your partisan view, you're going to cherry pick the pieces that you think wrong, and you're not going to have any knowledge whatsoever of the things that might be working. Maybe the state of Florida should have a blue ribbon group of employers and legislators and actually develop its own solution, building on a law that's not going to be repealed. I think mathematically the likelihood of repeal is nothing. Nothing. But it's a framework upon which other things can be done. Maybe we need a Federal Reserve type board in Florida to paint the future of healthcare in Florida instead of continuing this arms race we have where each sector is going after its own solution, none of which come together in better care at lower cost. Now, this law, you need to know, is about 40% of the way implemented. So any bankers in here? Can I see banks? You guys know about Dodd-Frank, big piece of legislation? It's less than 30% implemented. We have an unrealistic view of how laws are made and implemented. There have been 70,000 pages of rules written since the Affordable Care Act was passed. And there will be another 200,000 pages of rules written before it's fully implemented. It will be implemented over 10 years. Medicare was implemented over 4. The Medicare Modernization Act I referenced implemented over 3. Here's an irony. When Medicare was passed, it was very unpopular. The Medicare Modernization Act that's passed, that's now wildly popular with seniors, was wildly unpopular when it was proposed. So we shouldn't be fixated on the public's opinion of the Health Reform Act. We should be passionate about fixing the system. And it's possible you can fix the system, reduce cost, cover more, and improve outcomes. But it means all the cards have to be on the table, and this is not about protecting any part of the status quo. No part of it. And that's where politicians are corrupted by the special interests that say, I'm okay, they're not okay, here's my check. I see it every day. You've seen it. That's the reason this is going to have to be a populist movement, the reason it's going to have to be led by, I think, employers. So I want to stop there. Tammy and Leslie are going to get some mics in front of people that have questions about any part of this reform stuff and any of this that I might not have mentioned or you're interested in, and we're just going to kind of have an open mic, okay? So this is any question that's come up that you think, and anything goes. All of you read it, right? All of you follow all this stuff. And what? Here's an interesting factoid. I'm a data guy. You know what the average consumer's daily news consumption appetite is? 12 minutes. Most of that through mobile technologies. Only old geezers like Mike and me watch news now. And there's actually more time spent on games than news. That's why this is a tough discussion. What questions do you have? Yeah.
Thank you so much. My name is Leah Kennard, and I'm the president-elect of the Florida Nurses Association.
Yeah.
So you can assume I have a bias.
I'm okay, you're not okay. Think those docs aren't giving you enough respect?
That's really
Think that
not,
scope of practice isn't wide enough?
Actually, I think the public gets the best care when they get the best of medicine, the best of nurses, and the best of all disciplines.
Can we afford it?
Well, I think if we teach them what questions to ask, and I think that's a major public interest that I have.
Legislature in Florida could actually pass legislation to reimburse physicians for educating.
Yes, and reimburse any discipline for educating. But I have a question and a comment. My question is of the theoretical nature, and that is how you see the ACA and the work of Clay Christensen in describing medicine and the changes that are occurring in medicine in terms of precision medicine and chronic disease management. And what I have a bent toward his work because I think that he describes what can change regardless of legislation and what is changing. So I want your comments on that, but before you go, I have another comment.
Shoot.
That is, the blue ribbon panel needs to include nurses.
I would have expected no less from you. Let me remind you, again, there's an interesting section of the Affordable Care Act, Section 5, which says we have to train a whole new healthcare workforce. It says it has to be person-centered, it has to be team-based, it has to be technologically literate, has to be paid on the basis of results as a group rather than individual accomplishments, and it has to use a view forward of clinical innovation, not a rear view mirror because yesterday it required an admission, tomorrow it must require an admission. 40% of the visits to primary care do not require anybody touching you, and we pay for those. 40% of the visits. So, you know, the role that nursing plays, I happen to be the dad to an advanced practice nurse. She was moving to med school in pediatrics, chose APN, and I get this sermon every time I get to Nashville. But it's not about nursing any more than it's about nutritionists, any more than it's about prophylactic dentistry, mental health. We have a collection of professions that have to be together managing populations. And there are going to be certain interventions that are best managed by certain of those disciplines. But the future is I'm going to go to Sam's Club or Walmart, and I'm going to be managed by a team. And there will be one go-to person on that team for me, and that person may be a nurse. It's interesting, this is I follow healthcare. There are 192 countries, and I run monitors on 63 of those countries. We're a country that underutilizes nursing. And yet, when we look at these retail clinics, back to your Clay Christensen stuff, Clay's a buddy of mine, We got 3,000 of these retail clinics out there for these 12 very uncomplicated conditions. 70% of the people going to those clinics are people with commercial insurance that could go to a doctor. They have a doctor. They're going because it's convenient and, as it turns out, as safe, and it's $59 a visit versus $138 at the doctor's office. So we're going to find a whole new way of delivering healthcare services that are going to be technology-driven. But what degree is after a person's name? If there's anything that has hurt this move toward a better system of care, it's all the sectarian intramural conflict. I see it every day in Washington. When AMA walks out the door, ACS, American College of Surgeons, walks in. American College of Surgeons walks out, and then we've got the bariatricians that walk in. When they walk out, ANA walks in, and everybody is in there to say, listen, I know you're interested in them, but don't forget me. That's why it's going to take this group to change that. So I happen to believe we could get a lot more value out of nursing, but nursing needs to fix itself as well. Yeah.
Good morning. I'm Doug Calder with the Vaccine and Gene Therapy Institute.
Yeah.
My question, or maybe it's more of a comment from you, relates to the apparent disconnect in the Healthcare Reform Act, where it doesn't really recognize innovation. While we're talking about healthcare affordability, at the same time, the National Institutes of Health, their funding is being cut by billions and billions of dollars. And it seems to me, like the last person asked, precision medicine, innovation, biomedical discovery, new drugs being developed, that's going to be eliminating disease.
Let me get some facts on the table here. Innovation in the healthcare industry is not just what is funded through the National Institutes of Health at $30 billion a year, which parenthetically in the Stimulus Act got an additional $10 billion bump for our inspectors' vote, if you remember. So innovation in the healthcare system of the U.S. is another $70 billion being spent by medical device and health IT companies and others. It's not just NIH doing basic and applied research. That's just a misread. Innovation is being challenged in the biopharma world by virtue of two difficult dynamics. One is the risk of a compound from bench to bedside. How do we get it to market? 9 to 17 years, $1.2 billion to do that. So how many of those do you do? Reading a study this week, we've got 90 different compounds being studied for Alzheimer's right now. 90. So that means 86 of those are going to lose. So do policymakers prompt risk takers in the private sector to make those bets? They're looking at that in places like Canada and others, new models, instead of just playing the game, it's about the NIH's funding. Here's the thing we've got to be careful about. Innovation in the healthcare system is not driven only by genotypic information that's coming through basic research in the NIH. Process improvements, how we do what we do, is perhaps the greatest opportunity for innovation in the near term. These retail clinics were not anything anybody asked permission to do. We've got Walgreens out there. Walgreens didn't go to HHS and say, we'd like to open a retail clinic. So I think we're going to stumble through the question of, in the life sciences, how we can more effectively integrate. It went from personalized medicine to patient-centered to precision medicine. That's going to slow down because the funding isn't there. But the innovation in how the system is structured, delivered, and operated, there's huge opportunity. Last point. I was at J.P. Morgan in San Francisco, big healthcare summit last Monday. Why, if there's no opportunity for innovation, is investing in healthcare by private equity at record levels. They're not betting on old bricks and sticks. They're betting on all these new ways of doing things. So I think it's a misread to think there's not a lot of innovation opportunity. But again, we all tend to filter it through our own lens. So when I was at Vanderbilt, we did about $100 million a year on genotypic research. And my clinicians would have responded the same way you do. But in my world, looks like they're shutting the pipeline. They are. It's a fact. But it doesn't mean innovation in the system isn't exploding. Just that one doesn't get its fair due. I can name another 15 sectors that are going to get shorted over the next 5 years. That's one. Yeah.
We have time for 2 more questions.
Okay.
We're going to have Daniel, and then we're going to have Dr. Pigman.
Can you give me your impression of both mental health parity and the essential health benefit? Good ideas, bad ideas, what you think the impact is?
Yeah, so back up. What the essential health benefits are intended to do is these 10 categories that every health plan, employer-sponsored or through an insurance company, are to provide. And these 10 categories were to allow Joe Sixpack to compare products and to allow employers to offer parity with their products. And is it a flawed overkill? Yes. Are these 10 essential health benefits of equal value? No. Is mental health among the most significant and important of those 10? Absolutely. Now, here's the biggest changes you'll see, and this is one that employers should kind of noodle a little bit. We've got a bigger problem with anxiety and mood disorders, adult and adolescent depression in this country than we do obesity. It's just that we've separated in the system mental health and physical medicine. And in Florida, I've been doing this a long time, you actually institutionalize the firewall between the two. You wanted to make sure we didn't cross that. In the future, the Sam's Clubs and Walmarts will be noted by their ability to diagnose mood and anxiety disorders as effectively as they do flu. And counselors, master's-trained counselors, will be part of primary care. It'll not just be an MD or a DO. MD-ity, with all due respect in this room, is over. MD-ity is done. We're going to be delivering care through a variety of disciplines. By the way, just look at the data in the state of Florida. This would be another piece of homework on the number of people that end up in a hospital emergency room because of dental pain, because of tooth problems. And you're going to pay about $800 at a minimum a pop. And they're going to be told, we can put a topical on that, but there's nothing we can do. What a mess. What a joke. What a waste. So it's mental health, it's prophylactic dentistry, it's physical medicine, it's ophthalmic care. Yeah.
Thank you, Dr. Keckley. I'm Kerry Pigman. I'm a double evil. I'm both a politician and an ER physician doing all that high-charge, low-value care. But my question is, you've given us a lot of very good specific examples and suggestions. What would be your recommendation for a test or trial for the state of Florida? How would you suggest us moving forward? What would be your prejudice?
Well, I think about this a lot. One, it would require, in a county, taking the total spend for the human services programs. By that I'm talking about federally qualified health centers, community mental health clinics, and merging that with the delivery system. We operate duplicative systems. Two, it would be capitating the population and managing to outcomes that are set at 3, 4, and 5 years out, so that I can do not just the low-hanging fruit. What happens in a lot of these models where we're modifying behavior is, well, simple. If I ask you if you think it's important to lose weight, everybody in here would say yes. And then I put an incentive in place, and those of you that are already working out are likely to benefit from the incentive 6, 12, and 24 months from now, even though everybody would use it in January. Everybody would use it 1 month. So we have to have sticky incentives, sticks and carrots, and those sticks and carrots are tied to the provider teams as well as to the individual. The data says that sticks work better than carrots. Sticks get the fat people that won't walk and eat better to do it. Carrots don't. Period. Third thing I would do is I would eliminate payment for each piece. I would only write one check, and I would force the Sam's Club to distribute that per the severity of that particular population. Here's the last thing I'd do. I would put more value in outcomes than I do the patient experience. One of the big problems we have right now is that when the system is being measured for its success, its effectiveness, we're equating patient experience with an outcome, a clinical outcome. If I tell you that I'm going to change the way things operate, you're not going to be happy. If I say that's important, that you be happy, then I should just continue the system the way it is, Tom. I should let everybody get whatever they or their doctor think they need, pay 14 cents on the dollar for that, and some other generation has to pay for it. That got us into the problem. So that's my carry. The last thing is, we can't be fixated on whether the public's happy with these changes. It takes gutsy leaders who understand the system of care, and we calibrate to a better system that's more efficient, it's safer, it gets a better outcome. And here's an irony, and I'll close with this. One of the great myths of this debate about health reform is that supposedly we've got the best system in the world. We've got the best healthcare system in the world. That's not true. It's not true. Parts of our system are the best in the world. We're among the best at keeping people alive at the end of their life. We're among the best at getting drugs sooner. We're among the best at getting technologies, 3.0 magnet MRIs. We've got more PET scans, more PET scanners in Florida than in Canada. So we do some things pretty well at a cost that's 50% above any other industrialized nation. And what we don't do well is prevent bad things from happening. We don't do a good job of balancing prevention and sick. So I think we've got to balance that. I was fascinated in the last data we pulled, 32,000 interviews in 12 countries, that on levels of satisfaction with the system, the French and the Swiss were the high, and the U.S. was 11th. So we can't be here bashful about challenging the status quo and fixing it. And that's what I'd leave you with. You folks, we're not going to fix it in Washington. We made a mess of that. It's going to default to states. And that's what AIF, that's what you guys could pull off. And I don't think anybody in Washington is going to look back. The Affordable Care Act is now the law. But building on that, something good could happen here. Thanks.